As far as treatment in areas that do not have specialists, patients rely on their primary care doctors who they have long-standing relationships with. We don't have disease-modifying therapy for Alzheimer's disease, but the approach with the primary care physician, it should be focused on wondering about falls, wondering about their needs. How is the patient safe in the home? And I want to bring up checking even for firearms on the home is important, and that's what we pre-screen here at Montefiore. We've actually found that we've actually had emergency situations where patients have had suicidal ideation. As you may not know, but the suicide rate and depression is very high on the elderly, especially with neurodegenerative disorders. So the expression of feelings may not be there in some of the frontal temporal dementias or variants of primary progressive aphasia. So it's an under-recognized symptom, and we've actually had patients who have had suicidality or homicidality, behavioral manifestations associated with Alzheimer's disease, and the neurodegenerative disease is prevalent. So we actually, pre-screening and asking again about safety in the home, invoking with our social worker the mobile services is important. I think that we need to be more comfortable, and we need to consistently ask about that in addition to driving safety. As you know, navigating through New York City is a challenge as is, and we ask about driving at every visit. There's no New York State regulations on driving and reporting of driving. You can report a patient who may have difficulty, but there's no stringent stipulations. They vary from state to state, but it's an important question to ask. We've teamed up with our Berk partners. They have a formal driving evaluation program which evaluates patients who may have had traumatic brain injury, who may consider driving after, who may have memory problems, maybe they're progressing from mild cognitive impairment to mild Alzheimer's disease, and the family can't take away the keys because that's the one thing that's actually keeping that patient independent. It's often a struggle that we see, so we've teamed up with some of the community-based organizations for that. But it's an uncomfortable situation. What if you're a cab driver? What if you depend on that as a limo driver as a source of your income and you're now impaired? It's a difficult discussion, but I always say, remember who's on the road with you, and then it becomes a lot easier to navigate that. Well, we try to stay away from the politically heated with just a yes or no answer, and we actually screen every patient for depression. Every patient is screened for thoughts of harming themselves or other people. So that's done at every single visit through validated tests. So the patients are assessed, and what's interesting is that these patients are screened for depression, and we have previously instituted this through the Leslie R. Samuels and Fan Fox Foundation grants, and over 47% of our population not previously recognized as either mild or moderately depressed. We have to assess for any intents. We work closely with the psychiatrist, the mobile crisis services, so it's a team-based approach to make sure that the patient's safe. We've had instances where we've had to transport a patient from our outpatient office and work with other systems or Montefiore Health System to transport a patient for inpatient psychiatric care. Again, part of that collaborative approach. We do have a psychiatrist on staff who does evaluations at the Montefiore Einstein Center for the Aging Brain. So these cases are discussed, and we have a close relationship with the community physicians if there's trouble in the community as well. We haven't had any of that type of experience, but making sure, and part of our teaching site is the recognition that a white coat doesn't save the young doctor, doesn't save the young clinician, and the recognition that there are behavioral disturbances that come with the patient population that we're treating, and that we need to recognize that. And number one is our safety, the safety of the staff, and obviously the safety of the patient. But there is that teaching that goes on throughout by the social worker, by the psychiatrist, reinforced with the neurologist, the geriatrician, to make sure that the next coming generation recognize that. For our caregivers, we actually have a support group for our for patients or relatives of patients or friends of relatives or patients with Alzheimer's disease. So that's run by our social worker. We're looking to expand that primarily because we have people that have requested it in Spanish as well. So that's our next move. So we actually will bring, we've brought in the New York Legal Trust Company to actually New York Legal Agency, which is here at NILAG, here at Montefiore. We've actually brought them in to educate our caregivers. So not only are we providing support, we actually try to do additional educational sessions that we do that after hours, where patients, so that our caregivers can, if they're working, can go to work. Luckily, we have the Alzheimer's Association, the Hudson Valley Alzheimer's Chapter. They have 1-800 100 Lines and Caring for Kind, the former New York City Alzheimer's chapter, and that's a 24-hour-a-day service. That's not for obviously 911 emergencies and when we need to educate our families about it, but there is 24-hour support and counseling there, and there is support groups throughout that. There is local state agings that we have to refer to, and again, it's referring back to the primary care doctor for those caregivers and recognizing that those caregivers need to have doctor's appointments. Their risk factors have to be controlled, and starting to educate the primary care doctors to recognize also the patient that's in the chair next to the person that may have a memory problem.